Hello guys, in this video we are going to see about hyperthyroidism. So hyperthyroidism is nothing but the overabundance of the thyroid hormone. So mainly we have two thyroid hormones. First is T3 as well as the T4. T3 is triiodothyronine and T4 is thyroxine. Okay. So we can also term it as thyroid toxicosis, means the overabundance or the overproduction of the thyroid hormones. So here the first disease is the Graves disease. Okay, in Graves disease uh, you can see the diffuse toxic goiter. Goiter is nothing but the enlargement of the thyroid gland. Okay, so this thyroid gland is a butterfly shaped. So what happens here? The diffuse toxic goiter happens in Graves disease. Okay, so this is the most common form of hyperthyroidism. So this Graves disease is actually a autoimmune disorder. Means antibodies will be producing, and this antibodies, it is TSHR antibody, will be binding and activating the TSH receptors, resulting in the overproduction of the thyroid hormone. So hyper means over. Okay, like overproduction will be there of the thyroid gland. Now, TSHR antibody is a long acting thyroid stimulator. So, what happens? They keep on stimulating the thyroid to produce more amount of the thyroid glands. So, what happens in Graves' disease? If you see the diagnosis part, antibodies will be elevated. Okay. Now, what are the signs and symptoms of Graves' disease? So first we can see here diffusely enlarged non-tender goiter will be there. So diffusely enlarged in the sense, what is the meaning of diffuse toxic goiter? Means throughout the neck. Okay, it is spreading throughout. So the enlargement will be there throughout the neck. So here other signs and symptoms are nervousness, irritability, anxiety, insomnia. Insomnia means sleeplessness, heat intolerance, profuse sweating, weight loss despite increased appetite. You'll have appetite, but still you'll have weight loss. Tremor, muscle weakness, palpitations, tachycardia. Tachycardia is nothing but increased heart rate, that is more than 100 beats per minute. Exophthalmos. Exophthalmos is nothing but the bulging of eyes, uh, causing the eyes to move out of the sockets. Then stare, lid lag. Lid lag is like upper eyelid will be higher than the normal. Then diarrhea, thrill and drool, that is the vibrations and the noise. Periorbital edema. Edema, we all know that this is swelling. So periorbital means around the eyes there will be swelling. Now, next disease is a plumber disease. Plumber disease is nothing but toxic nodular goiter is what you call as plumber disease. So this is less common than the Graves disease. So the incidence for this plumber disease is highest in patients whose age is greater than 50 years. So this arises usually from long-standing non-toxic goiter. Okay, so the stereotoxicosis occurs when one or more adenomatous nodules secrete excessive thyroid hormones. So this adenomatous nodules will secrete more amount of the thyroid, and that will causes the thyroid toxicosis. So here, if you see the signs and symptoms for plumber disease will be same as for the Graves disease, except that here you can see one or more nodular masses. Okay, so here ophthalmopathy as well as the diffuse glandular enlargement will be absent, but you can see in these patients there will be cardiac abnormalities like CHF, congestive heart failure, tachyarrhythmias will be common. Okay, so ophthalmopathy will be absent. Now, what are the other lesser common forms of hyperthyroidism? Are first one is Jod Basedow phenomenon. So, what is Jod Basedow phenomenon? Here, due to the ingestion of increased amount of iodine, there will be overproduction of the thyroid hormone. That means through diet. Okay, first one is through contrast agents. So in diagnostic purpose or some other purpose, if you are ingesting more amount of iodine, or through drugs, if you are a arrhythmic patient and you are taking anti-arrhythmic drugs like amiodarone, what happens is that you will be having more amount of the you are ingesting more amount of iodine, and that causes overproduction of the thyroid hormone. So what happens is, if you are taking amiodarone 200 mg, that patient will be ingesting 75 milligram of organic iodine. So that is what we call as a Joule-Briscoe phenomenon. Second is a factitious hypothyroidism. So here what happens? The abusive ingestion of thyroid. That is for the weight loss. For weight loss, if you are taking thyroid hormones, that is known as factitious hypothyroidism. So here how the diagnoses are done. So in the diagnosis part, if there is no glandular swelling, or if there is no exophthalmos, there is a bulging of eyes, and if there is no autoimmune activity like antibodies are present, then you can confirm or you can assess that that patient is having factitious hypothyroidism. And the last one is subclinic hyperthyroidism. So in subclinic hypothyroidism, there will not be any clinical symptoms, okay, but there will be normal free triiodothyronine as well as free thyroxine, okay, but the TSH will be below the or lower than the lower limit. So it will be like 0 less than 0.4 milli international units per liter, okay, 0.4, okay. So this is what we call as the subclinical hypothyroidism. So in subclinical hypothyroidism, what happens is that there will be no clinical symptoms, but the patient will be having TSH below the lower limit. Now next one we are going to see about, this is very important, what is the difference between hyperthyroidism as well as hypothyroidism. In hyperthyroidism, you know that the T3 and the T4 level will be more, the thyroid production will be more, and in hypothyroidism the T3 and T4 level will be lesser. But in hyperthyroidism, either one increases or both increases, but the TSH will be, that is thyroid stimulating hormone, will be lower than the normal. Okay, that is very important. And in hypothyroidism, what happens is that the T3 and T4 will be very less, as well as the TSH will be higher than the normal, because thyroid will be keep on stimulating, and thus what happens, the TSH value will be very high. Now the therapeutic agents, mainly we are using the antithyroid agents are thioamides. So in thioamides we have mainly two drugs, propylthiouracil, that is PTU, as well as methimazole. So what is the main mechanism of action of these two drugs? So what they are doing is, here what the problem is that the thyroid gland is producing more amount of the thyroid gland, right? Thyroid is producing more amount of the thyroid gland. So this drug will be interfering with the thyroid hormone synthesis, okay, and they will be inhibiting the iodide oxidation and coupling. So this is the main mechanism of action of these two drugs. They are interfering with the thyroid hormone synthesis as well as inhibiting the iodide oxidation and coupling. So what is the goal of the therapeutic uses, or you can say what is the goal of the treatment? Okay, so the goal is treatment for remission. We have to diminish the severity of the condition, okay, that is the treatment for remission. Second is adjunctive therapy with the iodine 131. Iodine 131 is a radioactive element, so we can so with the primary treatment we can use this treatment also. And the preoperative preparation is also done. In case of surgery, we can give preoperative preparation. Now we are moving to the dosage. So propylthiouracil will be giving 300 to 450 mg per day. That is the maximum limit. Okay, that will be giving in 3 divided doses at the initial stage. So what happens? This 300 to 400 450 mg you can give us 100 to 150 mg every 8 hours, like morning, afternoon and evening. You can give 100 to 150 mg. You can give 100 morning, afternoon as well as the evening. And then what happens if the disease is very severe? Okay, in adult what happens, we can give 600 to 900 mg per day. Initially you can give 600 to 900 mg. That will be continuing for 2 months. For 2 months you will be giving 600 to 900 mg initially, and then you will be giving the maintenance dose of 100 to 150 mg per day. Can be given as single or divided dose into 2 doses. Okay, morning and night you can give. Then you will be continuing this for 1 year. After that, after 1 year, you will be discontinuing this over 1 to 2 months, because we cannot discontinue it suddenly, because it will have some other problems. So you have to gradually discontinue the drug while monitoring for the signs of recurrent hyperthyroidism. So there's a chance of recurrent hyperthyroidism. So if there is a recurrent hyperthyroidism or a recurrent episode is there, it will be happening after the discontinuation. Within 3 to 6 months there will be recurrent hyperthyroidism. So you have to monitor that. You have to monitor for signs of the recurrent. It can happen again. Okay. So in case if it again happens, okay, again hyperthyroidism occurs, you have to restart the agent or you have to use the alternative therapy. Okay, so the alternative therapy is thyroid gland ablation or removal. Okay, so you can either go for the surgical procedures now, or you can go for the decrease the function using the radioactive iodine, that is iodine 131. Okay, these are the alternative therapy you can use. Now you can see here the FDA black box warning is there for propylthiouracil. So what is the black box warning? Severe liver injury and acute liver failure. So this acute liver failure is fatal, means it causes death. Okay, so what happens? This is reported with propylthiouracil. So the patient who is taking this or administering propylthiouracil have a very high chances of getting this severe liver injury. Okay, so we have to monitor. So this is a warning by FDA. Now the second drug is the methimazole. Here the dose will be giving like 15 to 60 mg per kg. So based on the weight, we have to give the dose that will be given in 3 divided doses after 2 months of therapy. Okay, after 2 months of therapy, we will be moving with the maintenance dose. So the initial dose will be 15 to 60 mg per kg, but the maintenance dose will be 5 to 30 mg per day. Okay, so this has to be continued for 1 year. After 1 year, you have to gradually discontinue. Over 1 to 2 within 1 to 2 months, we have to gradually decrease the dose. We have to discontinue. So what are the major advantages of methimazole over propylthiouracil is that it is having lesser side effects than propylthiouracil, as well as it has longer duration of action and more rapid efficacy. But there is one problem with this methimazole. So in case of pregnancy, first trimester of the pregnancy, PTO is recommended drug of choice, because that is propylthiouracil is the drug of choice because methimazole has the risk of fetal abnormalities. Okay, so the newborn baby will be having some problem. Okay, the fetus will be having problems. So fetal abnormalities will be there. So we will be going with the, so during first trimester we will be recommending, the physician will be recommending the propylthiouracil, but after or during second trimester we can resume with the methimazole. So this is all about the hypothyroidism. The next part of the video will be coming soon, so please like, subscribe and share.